Hello everyone, I'm Dr. Lowell Ku, and I'm a reproductive endocrinologist and infertility specialist in Dallas, Texas. I'm the medical director and senior partner at the Dallas IVF practice, and my patients affectionately call me Dr. Knocked Up. Today we're going to talk about a very important topic, male infertility. We're going to talk about what it is, how can you find it, how can you treat it, and we'll go over all those today. First, let's talk about falling fertility. In 2009, The Economist predicted that worldwide there would be a drop in the fertility rate, and unfortunately, that has come true. Here in America, many celebrities have been very open about their infertility, and they've come forward and they talked about it online and on social media. And this has provided a strong voice so that there can be a very large recognition of what infertility is and what you can do about it. They've also made movies about male infertility, and here are a couple of my favorites. So let's start. What is infertility? Well, infertility is 1 year of unprotected intercourse without conception in women who are under the age of 35. Is it a big deal? It sure is. Over 2 million couples per year suffer from infertility, and over 6 million women between the ages of 15 and 44 have the impaired ability to have children. And over 9 million women worldwide have used fertility services. In general, 10 to 15% of reproductive age couples are affected by infertility. So when should you be worried? Well, the time required for conception is as such. About 57% of the couples who start trying will get pregnant within the first 3 months of trying. And after 6 months of trying, 72% of the couples should conceive. And by 1 year, roughly 85% of the couples should get pregnant. So that's a majority of couples who try should be getting pregnant by 1 year. And the remaining 15% in that following year, in another year, half of that remaining 15% should conceive. So by 2 years end, 93% of couples should conceive when they start trying. So when should somebody be worried and see a specialist? Well, if you're under the age of 35 and you have had 1 year of unprotected intercourse without success, it's time to see the reproductive endocrinologist and infertility specialist. If you're over the age of 35 or 35, after 6 months of unprotected intercourse, you should see a specialist. Or if you're any age and you have a known or suspected infertility issue, such as a male factor, you should see a specialist sooner. So what are the factors that affect fertility? Today we're going to talk about the male factors. But briefly, female factors comprise of 40% of the time as the sole reason as to why a couple will suffer from infertility. Factors such as ovulatory issues, anatomic issues, unusual problems, and unexplained issues. Those make up the 40% for a sole female issue. Men comprise of 40% of the reason as to why a couple will have infertility. And a combined female and male factor, 20% of the time, is the case. So essentially, 60% of the time, the male can be implicated in the couple's issues in trying to conceive. Okay, so I wish it were as easy as this. All you need is the egg and the sperm. And so today we're going to talk mainly about the sperm and what happens when you have not enough or none at all. So let's first talk about sperm. It takes roughly 70 to 90 days for the sperm to be created, packaged together, and matured so that it is ready for ejaculation. In fact, it takes 70 to 90 days, and within the first 70 days, that is when the sperm is being matured and produced and packaged together. And another 12 to 21 days are necessary for transport of the sperm from the testes through the epididymis to the ejaculatory duct. As it passes through the epididymis, the sperm obtains the ability to have sustained motility, and it's ready for ejaculation. And all this is directed by genes that are located on the Y chromosome. Roughly 100 to 200 million sperm are produced per day. So here we have our friendly sperm. But I wish it were that easy. In reality, this is what the sperm look like. So you can see there's a head, a mid piece, a tail, and an end piece. All four of those parts need to be put together properly for the sperm to be considered normal and usable. And what's interesting you see here is the front view, where it's a nice elliptical shaped head. And that's what we normally see and view as a sperm shape. But when you look at it on its side, it actually has an arrowhead type of shape so that it can build, or it can actually fight the defenses of the egg and enter into the egg and fertilize. So if there's any part here that is abnormal shaped, if there's too much or too little, then the sperm is rendered useless. Okay, the sperm's journey. From the time that ejaculation occurs, millions of sperm are dropped off in the vagina. And the cervix acts like a filter. It filters out a lot of the sperm. In fact, only thousands make it into the uterus, and a few hundreds make it to the end of the tube. So essentially, though about 1,000 to 2,000 sperm make it into each fallopian tube with ejaculation into the vagina, only a few hundreds make it to the end of the tube where the egg is waiting for the sperm. So very few make it from the beginning to the end. So what happens if we have too few or no sperm whatsoever? Well, if you suspect that, what should you do? Well, the male partner should be screened. Well, when should you suspect for screening? Well, if you have any sort of concern that the male partner has a fertility potential issue, then the male partner should be screened. If there are any male infertility risk factors that are known, such as bilateral cryptorchidism, where the testes did not descend, and you know that history, then the male should be screened. Or also, if there's any female risk factors, such as advanced female age, the male also should be screened at the same time that the female is being screened. Further evaluation of the male partner should also be considered if there's no known reason why the couple is having infertility, or if the couple is being treated for female infertility and yet the infertility persists, then the male partner should be screened as well. So in general, if there's any doubt, screen the male partner. So once the male goes to get evaluation, what happens? Well, first, a complete history is obtained to look for any signs of male infertility risk factors, such as congenital genitourinary defects, abnormalities of puberty, gynecomastia, trauma to the testicles, surgery to the testicles, history of chemotherapy or drug use, hot tub use, or even the cryptorchidism like we talked about. For example, if there's also any family history of infertility, especially in the males of the family, that should also be something to note. Additionally, a physical exam should also be performed, and it should be comprehensive. And even gynecologists should know how to perform a physical exam on the testicles. They should know, OB/GYN should know that testicular sizes should be normal in length at 4 centimeters and have a volume of around 20 milliliters. If it's anything more or less than that, that's an issue that needs to be evaluated. So what sort of tests are run on the male? Well, the number one test for male infertility evaluation is the semen analysis. And that semen analysis should be repeated 1 month later to make sure that the normal semen analysis is persistent, or if there's any abnormality seen on the first semen analysis, that it is persistent in the second semen analysis. If there are any abnormalities noted on the semen analysis, then the male partner should be referred to a urologist or a sperm specialist, and the female should be referred to the reproductive endocrinologist and infertility to prepare for treatment. Once the male goes to see a urologist, the urologist will likely perform some blood work and a sonogram of the testicles to make sure there's no abnormalities noted in the anatomy of the testicles. And for example, we want the best of the best sperm swimming to the egg. Okay, so a semen analysis. What exactly is found on a semen analysis? Well, here there are many parameters that we look at, but here are the main 6 parameters. Number 1 is the volume. You should have at least 1.5 milliliters to 5 milliliters in the specimen that is produced. And within that specimen, there should be at least 15 million sperm per milliliter. And of the sperm that's produced, at least 30% must be motile or swimming. And at least 4% of the sperm that is produced must be packaged properly and look normal with 1 head, 1 neck piece, 1 tail, and 1 end piece. And at least 4% of the sperm must be normal shaped. And at least 3, a level of 3 for progressive motility. So the sperm, though it could be moving in place or twitching in place or swimming in circles, that is considered motility. However, the most important type of motility is progressive motility. The sperm have to swim forward and make it to the destination of the egg. And so at least a level of 3. And the total motile sperm count must be at least 5.85 million moving sperm per specimen. If there's anything abnormal on this semen analysis, then that's an issue. Now remember, the total motile count is the best overall quantitative predictor for success. Now, the semen analysis, remember, reflects the conditions that existed many weeks prior because it takes 70 to 90 days for the sperm to be produced. So when an ejaculate is produced, that is actually a snapshot of what happened 3 months prior, or 70 to 90 days prior. And so if a male partner is sick one day, then 3 months later, his sperm count, if checked, can be abnormal. Okay, so what happens when there's an abnormal semen analysis? What is it that can be abnormal? Well, I'm going to boil it down to some very basic abnormalities and problems. First, there can be a quantity issue. In other words, not enough or none at all. So you can see here that you have too few on the first picture here. Now it's always okay to have a lot, but not okay if you have too few. It can also be a quality issue. In other words, there can be an issue with the motility. In other words, there may not be enough moving sperm, or the sperm progression is not at a level of 3. The shape of the sperm must be normal as well. So sometimes there are abnormalities in the shape, and that can also render the sperm non-useful. So I love this little cartoon. I take it you haven't had sex for a while. You can see here it says normal sperm, which look like little tadpoles, and of course sperm that has been safe for a while turned into frogs. All right, so in more specific terms, the quantity issue. We call that, when there's a low sperm count, we call that oligospermia. When there's less than 15 million per milliliter. It's considered severe oligospermia if there's less than 5 million per milliliter in the specimen. And azoospermia is when there's no sperm at all seen in the semen. Or if there's a quality issue, asthenospermia means a motility less than 30% or a forward progression less than 3. Teratospermia means abnormal morphology, especially when the morphology percentage is less than 4. We call that low morphology. And you can see here that morphology consists of making sure that there's at least one head, one neck piece, one tail piece, and one end piece to make up that sperm. Sometimes the head is too large. Sometimes it's too small. Sometimes there are 2 heads. There are 2 tails. Sometimes the head shape is wrong, or the end piece or mid piece is abnormal. All of these types of sperm are rendered useless. So there are some other issues that can occur on a semen analysis. For example, there can be some things that can be reported as round cells. Round cells are essentially epithelial cells, prostate cells, immature sperm, and leukocytes, but they can't be differentiated on a semen analysis, a routine semen analysis. So if there are over 5 million round cells, then additional studies need to be performed to make sure that there's no infection present from a leukocyte that is seen from a leukocytopenia. Leukocytospermia. Leukocytospermia is implicated in the cause of poor sperm motility and function, but sometimes some studies have suggested that this may not be an issue. However, it's always good to look and make sure that a culture might be obtained so that you can make sure there's no infection. Okay, so what if there is a male factor and you find an abnormality on the semen analysis? What are some of the reasons for an abnormal semen analysis? Well, when there's a quantity issue, in other words, not enough or none at all, essentially it could be due to a number of reasons. Smoking can cause it. Marijuana usage can absolutely cause a lowering of the sperm production. Testosterone usage is likely the #1 reason that can lead to low sperm production or no sperm production. And the reason why is because the body, specifically the testicles, is always sensing testosterone levels in the body. If there's not enough, the testes will produce more testosterone. If there's too much testosterone in the system, the testes will turn off and say, you know what, we have produced enough testosterone, we need to shut the factories down for testosterone production. But when it shuts down the testosterone production, it also shuts down the sperm production. So that's why when someone takes testosterone and the testes sense that, then sperm production will cease. So it's very important to know that if you're taking testosterone, That could be the reason why you have no sperm on your semen analysis. Now, the good news is that if you stop testosterone or stop the marijuana, within 70 to 90 days, the sperm production will return. So that's the good news. Other reasons why there can be no sperm is a prior vasectomy, chemotherapy usage, or even if there's a low sperm count, it can be due to a prior vasectomy reversal attempt where maybe there's a constriction at the junction where the vas deferens has been repaired, and it just isn't letting enough sperm through. Now, another issue is called retrograde ejaculation, and that is where the sperm, though it should come out of the penis, it sometimes goes backwards and goes into the bladder. I know that sounds really strange, but that's very common in men who have diabetes or even prostate surgery. Or sometimes if there's not enough sperm on a semen analysis, it's because the guy missed the cup. It is very common that a gentleman may not aim properly and not all the sperm makes it into the cup. Unfortunately, just got to do another semen analysis and make sure that the sperm, all of it, goes into the cup. What if there's a quality issue? What are some of the reasons for that? Well, heat exposure to the testicles is the only reason that we can know of that can lead to a lowered sperm morphology. When the testes are essentially heated up, they will have a difficult time producing proper shaped sperm. Smoking also can decrease motility as well as count. All right, so what are some of the treatments for male factor issues? Well, if there's a quantity issue, make sure you treat the underlying problem. For example, if the male partner is taking testosterone or smoking marijuana, they've got to stop. And hopefully within 70 to 90 days, the sperm should resume to normal count. What if there's a mild oligospermia? In other words, between 1 and 5.85 million total motile sperm on the sample. Well, you can try insemination. Though it's not impossible for the IUI to work, the IUI success rate still will be a little lowered as compared to IUI using normal numbers of sperm. But since it's not 0%, IUI certainly is an option. And so here's an example of IUI, and we'll go over this in more detail in a moment. What happens if there's severe oligospermia, less than 1 million total motile sperm on the semen analysis? Well, the gentleman must be sent to a urologist for evaluation to make sure that there's nothing wrong with the testicles, specifically that there's no testicular cancer. And if the male has been deemed clear of that, then IVF with sperm injection, also known as ICSI, or intracytoplasmic sperm injection, can be used to increase the chances of getting pregnant. And here's an example of ICSI, where the sperm is drawn up into the microneedle and then injected into the egg. What happens if there's an obstructive azoospermia? In other words, there's no sperm in the semen analysis and it's due to an obstruction. Well, if it's a vasectomy, then the vasectomy needs to be reversed. Or if there's another type of obstruction, hopefully that obstruction can be removed by the urologist. Sometimes a urologist can do a fine needle aspiration and see if there's actually sperm production in the testicles, and maybe can harvest some of that sperm through something called TESE or TESE. That's testicular sperm extraction. And that sperm then can be used during IVF and injected into the egg, and then the couple can hopefully have a higher chance of successful pregnancy, of getting pregnant. What happens if there's a non-obstructive azoospermia? Well, unfortunately, if there's testicular failure and there's no way to return sperm production from the testicles, donor sperm is an option. What happens if there's a quantity issue such as retrograde ejaculation? Remember, we said that sperm should be coming out of the penis, but sometimes due to a route abnormality, the sperm gets rerouted into the bladder. Well, there is a way to get that sperm out safely and cleanly. Well, after ejaculation occurs, we have the patient urinate into a cup, and that urine sample is then collected. And that urine sample is spun down, and the sperm is separated from the urine. That sperm pellet is then reconstituted in some media, and that sperm can be used for either IUI or even IVF. What happens if there's a quality issue? How do you treat that? Well, treat the underlying issue. For example, if there's smoking, you gotta stop smoking. If there's heat exposure to the testicles, such as sitting in hot tubs, bathtubs, or saunas, then that's gotta stop as well. And then hopefully 70 to 90 days later, the sperm will return to normal quality. Some husbands can take supplements. such as vitamin C, vitamin E, zinc, and L-carnitine. These are all supplements that make healthy sperm. And sometimes if a guy is overweight, then the gentleman can lose some weight. And that's important because a healthy male can also produce healthy sperm. Now, sometimes if there's a lot of weight around and tissue around the thighs, that can create a little pocket of heat around the testicles, and that can change the shape of the sperm and lower the morphology. So if there are mild quality issues, IUI still is an option to try to increase the odds of successful to get pregnant. What if there are severe quality issues where there's, let's say, 0% morphology or 0% motility? Unfortunately, IVF with sperm injection is the only treatment for that. Now let's also talk about delivery issue. Sometimes a male has a problem delivering the sperm into the vagina. The way to correct that is to correct the underlying issue. Sometimes it's due to stress. Sometimes it's due to depression. The male partner may need to seek counseling. Sometimes it's due to medications that the male partner is taking. So if you can change those medications that cause low libido, then hopefully that'll improve the libido, and then intercourse can be pursued successfully. And what if there's difficulty ejaculating in the vagina? Well, sometimes the man cannot have orgasm in his wife. Well, what we'll have the patient do is they'll ejaculate into a cup. We'll prepare the sperm for IUI, and that's the way to get the sperm delivered to where it needs to go. Okay, so what is IUI? It's also known as intrauterine insemination. And the sperm is produced, it's prepared, and then it's placed past the cervix, also known as the filter, so that 100% of the sperm will make it in rather than very few of the sperm when sperm is dropped off naturally in the vagina. With IUI, roughly 10,000 sperm is delivered to the tube, whereas with ejaculation into the vagina, only about a few hundred make it to the tube. Now here's the way to prep the sperm, and here's another example of how IUI works. And I love this. Try to relax, Mrs. Carruthers. The fertility treatment will only take a moment, and that's artificial pollination. Okay, sperm parameters. Why do we check them? Well, they're very important because they also predict how well a partner will, or how well will a couple perform during treatments. So we know that an increase in number of total motile sperm inseminated is equal to an increase in probability of success. So the best results are achieved when the total motile sperm count that's inseminated is at least 10 million. Now remember, even if you had 30, 40, 50 million sperm going in, it doesn't necessarily increase the chances of success. You just need around 10 million at least. With IUI, if there's less than 1 million total motile sperm being inseminated in, unfortunately, you have lower chances of success. However, a male partner can produce 2 samples, and you can combine those 2 samples and to create a higher number of sperm that are inseminated. Now remember, strict sperm morphology also is predictive for IUI. So if the morphology is above 14% normal, great. That predicts a great chance for IUI success. But if it's between 4 and 14%, there's a lower chance of success. And there's poor chance of success if the morphology is below 4%. Now, it's not 0% chance of success, it's just lowered. So it's best advised that if a couple has, or if a male partner has less than 4% normal morphology, they need to consider IVF with sperm injection as a proper choice of treatment. Now remember, a sperm prep will increase the number of sperm, it will increase the number of moving sperm in the sample. It will not change the morphology itself. It may also increase the normal morphology of sperm in that sample, but it won't change the morph itself. Okay, IVF and ICSI. What's the difference? Well, with IVF, 100,000 sperm are dripped onto the eggs, per egg that is. Whereas with ICSI, the sperm is looked under the microscope, and the best sperm is drawn up into the microneedle and injected to the egg. And this is what it looks like. So if you're an OBGYN, what should you do if you suspect a male factor infertility? Well, first you can try talking to the male partner to correct the underlying issue. Next, you can maybe try some controlled ovarian hyperstimulation, where the wife will take, or the female partner will take, medications to increase the number of eggs that are brought forward, with medications such as Clomid or gonadotropins like Gonal-F and Follistin. And then you can combine that with IUI. However, you can also refer the male partner to the urologist or the sperm specialist, and the female partner to the infertility specialist to prepare for treatment. So what can a male partner do right now? Well, here are Dr. Ku's 7 T's, 3 to-dos and 4 don'ts. 3 T's to do. Number 1, take a multivitamin every day. That should help feed the sperm all the vitamins it needs to create normal, healthy sperm. Toss back water. In other words, remain hydrated. Also, thin down if you're overweight, especially if your BMI is over 27 kilograms per meter squared. Eat healthy and exercise is a very important part of that. Now, 4 T's that you need to avoid. No tobacco, no THC or marijuana, no testosterone usage or anabolic steroid usage, and no tubs, specifically hot tubs and bathtubs that tend to heat up the testicles for a prolonged period of time. So male infertility. In summary, if you suspect a male factor issue, test the male partner. The semen analysis is the most common first test to order for the male partner. If there are any abnormalities on the semen analysis, fix the underlying issue, or you can also refer to your urologist and refer the female partner to a reproductive endocrinologist and infertility specialist. Now remember, there are many very good and effective treatments for male infertility, so don't despair if you find or suspect a male factor infertility. Because in the end, these couples who have a male factor infertility have a very good track record of getting what they are dreaming of, a healthy baby. Thank you very much, everyone, for listening to my talk. I'm Dr. Lowell Ku, also known as Dr. Knocked Up. Thank you so much.